We were just busy coming off another war. And I hope people, I can see some people on there that I recognise. It's great, but I can't see the remaining 25. That's impossible. But I'd like to maybe make yourself known to the group. Ella, are you on the line? And Heather Walker, and I think we might have Bruce Gray as well. So are you around, Ella? Oh, that's interesting. Well, they're invited, so they may join us as we go along. Ella's the Deputy Director of Strategy at Royal Cornwall Hospital, and I think some of our improvement team are on the line. And Bruce Gray is from NHSE, he did some work with us in pathology last year. So he's joining for some just alignment and work they're doing nationally. So I think we've got quite a few slides. And Mark, do you want me to do the quick intro ones, or do you want to handle them?
You can do the quick ones if you want. Just think Sarah and I are here as well. I do enjoy this session. It feels like we're completing some success in the organisation. So yeah, I'm really excited to watch it. Thank you, Richard.
Yeah, and thank you both for joining. And I might apologise because there might be other people on the call that I haven't seen the names of. Oh, I can see some of our presenters lined up, which is very good. So welcome, Prodromus, because I'm not sure if you're first act on. So, but I'm just going to do a couple of intro slides. Can we do next slide, please? So just a reminder, we're part of this process is developing our quality management system, and this very much our report out fits into that around shared learning. So we could do next slide, please. And so remember, the three of the core principles that we're trying to create in people first is engaging staff with improvement and making sure it's really respectful, making sure we value how we're improving stuff with regards to patients and keep patients at the center of it, and enabling teams to drive improvements. But the reason why the big yellow blocks there is mostly we help people share ideas and get them done. And building that confidence and pace and that things can change is really important to the program. If we just could do next slide. And just wonder when we work with areas, and very much what's happening this week, by the way, if people didn't know, is ward managers and matrons are having days out learning how to do this themselves and lead the practice themselves, which is really great and an enjoyable time with a nice simulation. Thank you, Stephen Heath, he's on the call, he lent us one of them, but really clear purpose, using a structured approach to improvement, using metrics, creating an improvement huddle, and very much working with our team health routine to help teams become better teams. So that's what's behind it all. So what's the next slide? I think might be the agenda. So star turn first off. In a minute will be Prodromos. I hope I said that correctly. Please wave at me if I didn't. You might want to get you off your mic now, by the way, and get on. Who's done a really great project on his practice coach certification. So I'm sure Mark will be all ears. And we then got a pre-recorded session because someone's on maternity leave, and we didn't do it last time. So you will hear her talk about doing something next year. She means this year. So she's missed one report out on this. And then thankfully, we've got Wendy talking about her workshop, Kelly Haynes-Brown talking about the current work with amber boxes, and then Carrie Colleen's going to finish off with a lovely presentation around the CT colon pathway and the work they've done to improve that. So I hope you're really interested in the 5 presentations. I may chivvy you up if you're taking too long, by the way, so I do apologise about that. Maybe, Mark, do you want to say anything before we get started, or are you happy?
No, I guess the thing for me, Stuart, it's really nice to see different staff members coming through in the report out. You know, I'm passionate about all members of staff, but I'm really passionate about clinicians being involved in this. So I think this is really good.
Brilliant. So Bryony and Prodromos, you're away.
Oh, hi. I thought I was going to share my screen, but anyway. Hi, everybody. Thanks for the invitation. My name is Prodromos. I'm a neurology registrar at Dartford Hospital, and I'm here to present my practice coach project on creating a planned training-focused neurology registrar rota to improve our training experience. Next slide, please. There's 8 neurology registrars currently in the hospital, and we're based on level 10. I'm afraid I don't have any photos. They didn't let me. But most of the time we can be found in the emergency department. Next slide, please. That seemed to be also the main problem that I was trying to solve, because we, as registrars, we felt that we were offering a lot of acute services, but there was low number of general specialist clinic attendants by the registrars, despite them being available in the department, which often led to a lack of balance between service provision and training, which also led to higher burnout rates and people taking more sick leave and having reduced job satisfaction, which was also mirrored in the annual GMC training survey. Next slide, please. So this is a diagram of our performance in the past few years. The main metrics I used were the clinic numbers, the minimum clinic numbers a registrar would do, and the maximum ones, the number of subspecialty clinics. The more the merrier, because it's more training for us, and the number of acute clinics, the worse for the training experience, because it seems more like a service provision. The targets were laid out by Health Education England, and as you can see, in the past few years, unfortunately, we haven't been able to hit the targets. In clinic numbers overall, there's a big gap between the minimum clinics and the maximum clinics, meaning that the rota was unfairly created without anyone's fault. There's virtually no subspecialty clinics for some registrars and a lot of acute clinics for some of the other registrars, which led to the problem of the poor training experience that we were having. Next slide, please. So I tried to understand what was the main problem, what was causing the issue, and I found a few points. One significant one was that there was no centralized calendar of clinics. So unfortunately, we didn't know the when, where, or who was able to provide the training opportunities for us to access them. And part of the problem was that the consultant schedule was not visible in advance. So therefore, we couldn't plan the rota ahead of time. In the same context, there was lack of planning in the manager's process of booking registrars into clinics. It seemed more to be service-based and what the waiting lists were dictating rather than what we needed for our training. And additionally, there were no structured pathways for us to access training opportunities outside the neurology department, like neuropsychology or neurophysiology, etc. Next slide, please. So what did I do? I initially tried to calculate how we can allocate all of these service roles and training roles that a registrar can have throughout the year, and try to calculate how we can maximize our training opportunities without compromising acute care, and put it down in a spreadsheet. And that took into consideration every registrar's less than full-time status or the research needs, and we came up with some numbers. Next slide, please. Then all these numbers were allocated to different registrars in order for each and one of the registrars to maximize their training opportunities, the clinic numbers, and also to provide a fair distribution of the acute service roles, like holding the neurology bleep or the stroke bleep. Next slide, please. The next step was to create a training calendar, essentially, with all the clinics and training opportunities in a centralized list. And I did that with the help of the managers and the consultants, providing the schedules ahead of time. And then I forwarded this to the registrars, and they were able to essentially show their preferences and book themselves into the clinics that they wanted based on preference, and also what the clinical training attachment they were on at the time. Next slide, please. I presented this way of planning the rota to the consultants and the managers in November, and there was support to go ahead with it. And then I created a rota model based on on a step-by-step approach, which was taking into account all the preferences of the registrars and also the numbers from the calculations from step one. I gave it to the rota lead, who reviewed it and implemented it from December of 2022. Next slide, please. I collected the data about implementation of the project in December and January, but there's ongoing implementation in March and April, in February and March, and there's plan for further implementation from April to July to complete the whole year of training. Next slide, please. So the data from December and January was quite good. It showed good adherence to the model, and actually outperformance of the model, because the managers were also booking additional clinics to the ones we were requesting due to the needs from the waiting list and the need for outpatient care. So all the metrics that we used seem to have an improvement between 40% even to 900% in some of the subspecialty clinics, which were virtually none before the project, but now it seems to be much better. And the projection to the rest of the year, they seem quite positive as well. Next slide, please. So this is the improvement. You can see briefly that the clinic numbers have improved. The gaps between the minimum and the maximum has reduced. So that seems like a fairer rota. There's an increase in the number of subspecialty clinics and a drop in the acute clinics. Next slide, please. And if we take all that information and data and we apply this adherence to the model to the rest of the year, it seems that we may be even able to hit the targets even to make up for the underperformance in the first 3 months when the model was not applied. Next slide, please. So I surveyed my fellow registrars for the first few months of the model implementation of the project, and they all agreed that it improved their training experience, and they agreed to support it in going forward and stay implemented. Next slide, please. And maybe more importantly for the trust, they all agreed that if it was to be implemented for the rest of the year, they would rate the local training more highly at the annual GMC training survey. There were some ideas about extra support from management. And next slide, please. I highlighted one concern, which was sustainability of the change, sustainable change and standard work, which was, next slide, please. Which was what was really important for me as a learning opportunity about how to make the change sustainable. So I had to write down, put down in a step-by-step process of how to do this. Is just a sample. It's not the full sort of step-by-step process. But then I could hand it over to whoever will be doing the rota in the next few years. And it seems to be boosted by people's sort of positive experiences, and therefore hopefully whoever is going to take over the project or take over the rota creation will implement it. Of course, IT systems would help to make it more smooth, this coordination between the members. Next slide, please. As a final thing, I just want to say that all of these ideas come up with any improvement project, and there's a vision for sort of further implementations of wider training program improvements and training experience improvement. But I'm hoping to discuss this maybe at a later meeting if I have any success stories. So next slide. Thanks very much.
So Prodromos, I think, can I just say, and there's a few questions that people desperately want answers from because they're so keen. Really, really well done. Great piece of work. I'm sure there's a big round of applause coming your way from everybody on the screen. But I just want to field a couple of questions. I jumped in before Sarah asked a question, by the way. But do you think this has cost us anything in terms of to do all this, the change performance and the extra clinic? Has it cost us anything?
I think not. I think we were using opportunities that were going to waste. So now we use them better in the sense of registrars perhaps doing two things at the same time. We sort of stretched ourselves a little bit, and we were happy with doing that. In order to get into the training opportunity, so we used our time more efficiently, I think. So it wasn't much of cost us anything. I think we just made better use of our resources.
And there's a whole host of questions, but I want Mark and Sarah to ask theirs. So Sarah, jump in.
This is brilliant. I just want to say well done, and it's just fantastic improvement work. I'm really, really impressed. So my question is, as I put in the chat, how quickly could we roll it out to other specialties, and is there anything stopping us doing this?
I don't think there's anything really stopping us. I think it was just implementing the idea. I don't think there was anything too fancy about it. I think it's just, even if we don't use any fancy tech, we can implement into other specialties. I think there's a great opportunity here about doing planned rotas, because also from the manager's perspective, speaking to Donna, for example, who's our department manager, we can actually utilize our staff better, and we can dictate how clinics will work based on our waiting lists. Get the registrars into the clinics in a more planned way. So yeah, I think maybe using IT to centralize things so they're visible for everyone and planning ahead more easily, that might be something that will help. But I don't think it's difficult to implement it. Yeah.
Thank you.
Thanks.
Mark, jump in.
Yeah, I'm just staggered by the increasing training opportunity it gives you as a junior doctor. And I know we've got an HE triggered visit in neurology coming up soon, and I'd really like you to tell this story. I think it's fantastic. The other, well, it's an offer really, and a statement, is that we want to put on a People First event towards the end of April around medical education and training. And I'd love you to come along and present this, Prodromos, because I think it's fantastic what we can do that's within our gift. We've set ourselves an ambition to be one of the best places in the southwest to train in the next 3 years, and this is exactly the type of thing that will make it a great place for trainees to come to. So yeah, I'm really impressed. Thank you so much.
No, thank you. Thanks.
Podemos, you did a great job by it. There's a lot of questions we haven't answered, but I just wondered if while you're sat on the screen for the next calls, you might want to take a little view of some of the questions that have been raised. You've got some Jackie Hayden ones. I think there's a question there from Christine, but there's a few other questions there. Whether you could actually just provide some answers on the chat, would that be great?
Yes, absolutely. I'll just take the time to
Thank
answer
you.
them. Yeah.
Sorry I wasn't answering all the questions, but we've still got 4 more presentations to go. So and now how do we all follow that? We follow that with a pre-recorded one, I think. So, but on a similar topic, it's about junior doctors as well. So this is Hayley Johns, and I think the recording is going to start now. It lasts about 5 minutes, so please bear with it. And please, if you've got questions, please put them in the chat because we'll get them answered as well. Thank you.
Hi, so my name is Hayley Johns and I am support manager. My coach project was based on improving sickness reporting and return to works for medical staffing across the service line. It became quite apparent when I started the job that it was something that wasn't being looked at, not just within the service line, but across the trust. And it's something that I was quite interested in improving. So my problem that I started out was that as a patient, I would